We've all had a headache. It's probably one of the most common complaints out there. But when you're in a clinical setting, how do you tell the difference between a routine, miserable headache and a sign of an absolute catastrophe? What makes that head pain a true code red?
Well, that's exactly what we're going to get into. We're not just going to memorize a checklist of warning signs. No, we're going to dig into the why. We're going to connect every single red flag back to what's actually happening inside the patient's head.
So here's our game plan. First, we'll get into the nuts and bolts of how headache pain even happens. Then we'll talk about the most important fork in the road, primary versus secondary headaches. After that, we'll meet our best friend in diagnostics, the SNOOPP Mnemonic, and we're going to tear it down letter by letter.
Right, so before you can spot the problem, you really have to understand how the machine works. Let's start with the absolute basics of head pain.
Here's something that might surprise you. Your brain tissue itself, it doesn't actually have any pain receptors. It can't feel pain. So where does the sensation of a headache come from? It comes from irritation of the structures around the brain, things like the meninges, those protective layers, and the big blood vessels. All of that is wired up by the trigeminal nerve. And that whole setup, that's what we call the trigeminovascular system. Think of it as the pain engine. So how do you turn this engine on? It all starts with a trigger. Could be stress, could be something way more dangerous. That trigger activates the trigeminal nerve endings, which then release this key chemical messenger, a neuropeptide called CGRP. CGRP is a huge player. It causes blood vessels to swell up and get inflamed, and that's the throbbing pain signal that gets sent up to your brain. You'll want to remember CGRP, by the way. It's the main target for some of the biggest new migraine drugs out there.
Okay, now we're at the first and honestly the most critical decision point when you see a patient with a headache. Is this a primary or a secondary problem? So the official classification breaks it down like this. A primary headache, like a migraine, is when the headache is the whole problem. It's like a faulty fire alarm, it's loud, it's painful, it's incredibly disruptive, but there's no actual fire. A secondary headache, on the other hand, is just a symptom. The fire alarm is going off because the house is actually on fire. There's a tumor, a bleed, an infection. Your job is to find that fire. And this right here, this quote says it all. The stakes are as high as they get. If you mistake a bleed in the brain for a common migraine and send that patient home, well, the consequences can be absolutely devastating. So how do we make sure we don't miss that fire? How do we hunt for these dangerous secondary causes in a systematic way? Well, we use a mnemonic, a really powerful tool designed to catch every single red flag. Meet SNOOPP. Get this burned into your brain. Each letter stands for a high-risk feature that should make you slam on the brakes and investigate. So let's break it down letter by letter and connect it all back to the why. All right, let's kick it off with the first two letters. S for systemic signs and N for neurologic deficits. The S. If your patient has a headache plus systemic symptoms like a fever or major weight loss, you gotta think bigger. A fever is not part of a classic migraine, but you know what it is part of? An infection like meningitis, where the body's inflammatory response is directly irritating those pain-sensitive meninges we talked about. This tells you it's not just a head problem, it's a whole body problem showing up in the head. Now for N. This is crucial. A true primary headache should have a completely normal neuroexam. The second you find any focal deficit, some weakness on one side, a vision change, a seizure, the game changes completely. That points to a structural problem. Something is physically there in the brain, a tumor, a stroke, an abscess, and it's pushing, stretching, or damaging tissue. That patient needs imaging, and they need it now. Okay, let's keep moving. Next up are the two O's, and these are all about timing and who the patient is. The first O is for onset, and specifically a thunderclap headache. This is a neurological emergency, full stop. We're not talking about a headache that builds over an hour. We're talking about one that goes from 0 to 10, maximum intensity, in less than a minute. It's explosive. And why? Because that pattern just screams subarachnoid hemorrhage. An aneurysm ruptures, blood floods the brain, and that blood acts as a massive sudden irritant to the meninges, triggering an unbelievable wave of pain. The second O is for older age. Look, the patient's age is a huge diagnostic clue. Primary headaches, like migraines, they almost always start when people are younger, teens, 20s, 30s. So if you have a patient over 50 with a brand new, significant headache, that is immediately suspicious. The chances of it being something serious, like giant cell arteritis or a tumor, are just so much higher in that age group. And we're at the home stretch. Let's tackle the two P's. These are about how the headache changes over time, and what you can actually see with your own eyes on an exam. First P, pattern change. A patient who's had migraines for 20 years knows their headache. The real warning sign is when that familiar pattern changes. If their headaches are suddenly getting worse and worse, more frequent, more intense, that's a huge red flag. The mechanism makes perfect sense, right? You have to wonder if there's something growing in there, like a tumor, that's slowly but surely stretching those pain-sensitive structures more and more each day.
The final P is for papilledema. Now, this one's unique because it's not something the patient tells you. It's an objective sign you find on your fundoscopic exam. Seeing a swollen optic disc is like having a direct window into the skull. It tells you, with certainty, that the pressure inside that head is dangerously high. And that high pressure is what's causing the headache by stretching the dura and blood vessels we talked about right at the start.
So let's wrap this all up. What did we learn? First, that headache pain comes from the trigeminal vascular system, not the brain. Second, the single most important job is to figure out if it's a primary, a faulty alarm headache, or secondary, a real fire headache. To do that safely, we use the SNOOPP Mnemonic as our guide. And the main point here is that every single one of those red flags is tied to a clear, understandable why.
See, once you understand the why, SNOOPP stops being just a list to memorize. It becomes a real diagnostic framework. It's not about just checking off boxes anymore. It's about recognizing the physiology of a disaster and having the tools to stop it before it's too late.